So this first slide is showing the difference between an ischemic and a hemorrhagic stroke. This is a CAT scan, which is one of the very first tests that you're going to get on a patient who you think is having a stroke. Our important thing to remember here is we're trying to differentiate if it's an ischemic or a hemorrhagic stroke. Ischemic, you're going to see areas of dead cell tissue, so they're going to be darker. Hemorrhagic, you're going to see areas of lightness, which is your blood. So all strokes cause decrease in oxygen and glucose to the cell and decrease in waste product removal from the cell. There's two important types that we're going to talk about. The first one being ischemic. This is the majority of our strokes. It's 80 to 85% of the strokes, and these are due to occlusion. Hemorrhagic stroke is the other type of stroke we're going to talk about, and that's where a vessel ruptures. The different type of ischemic strokes, or their subtypes, includes thrombolytic stroke. This is where you have atherosclerosis. Then you have occlusion of the artery. It decreases the blood flow away from that clot. This is the most commonly happens at a bifurcation or branching out of the carotid and vertebral arteries. So basically, a thrombus breaks off from the plaque, and it travels and then it occludes some area in the brain. Embolic stroke, this originates from a blood clot or an emboli. So it's traveling through the cerebral artery, and it causes occlusion and decreases the blood flow distally. Usually is blocking the middle cerebral artery. Emboluses or emboli commonly come from the heart. TIA or transient ischemic attack. These cause temporary symptoms. They last only a few minutes and they precede an ischemic CVA. And RIND, it's a reversible ischemic neurological defect. It's temporary like a TIA, but it lasts longer and it can be up to a day. Here's a picture of an ischemic stroke. Hemorrhagic strokes, the vessel ruptures and it can occur with cerebral aneurysms, uncontrolled hypertension, and AV malformations. So your brain metabolism is disrupted by exposure to blood. They will have increased intracranial pressure because of the presence of blood in the subarachnoid space. And then there's compression and secondary ischemia from reduced perfusion. So basically that pressure inside the skull will then, wherever there's pressure put on, it will also have ischemia because it's being pushed out. So it causes additional injury to the brain. Aneurysms and AV malformations and hypertension, they most often cause subarachnoid hemorrhage. That's the area and layer of the brain that they have hemorrhaging in. The most common causes are a leaking aneurysm in the circle of Willis. This is at the base of our skull, and it's kind of where all of the arteries start out and then they branch out. So there's a lot of bifurcations or branches. So this is a very common place to get an aneurysm. An AV malformation, you're actually born with it. It's an arterial venous malformation, so it's a jumble up kind of mess of arteries and veins mixed together, but they're weak, and so when we have hypertension, they can rupture. So this is just a picture of the aneurysm leaking into the brain. So FAST. We've all been taught this by lots of public health campaigns. This is how we can find out about strokes. So F is for facial drooping. We're going to want the patient to smile if we see that one side is not going up. Or if they have a toothy smile, you can count how many teeth are on each side of the middle. And then you can also notice some subtle changes about drooping. A is arm weakness. You have them raise their arms both at the same time, and if one drifts or if one cannot be raised, they obviously have some arm weakness. S is speech difficulty, and this could be garbled, it could be non-existent, and it could just be nonsensical, so that would be a speech change. And then T is time to call, so that we need to make sure family and friends are calling 911, but they're also noting the time that symptoms start, because that's very important to get a patient into treatment. So that FAST assessment is called the Cincinnati Pre-Hospital Stroke Scale. The Glasgow Coma Scale is also important. We should know this. We should be doing an assessment on this every clinical day, but this is our gold standard neuro assessment. So it's important, and it's a base of most of the scales concerning strokes. The NIH stroke scale, it's important to go to the link that I've posted here so that you can read through it, understand what it's doing. So it's standardizing the physical exam of patients who have strokes. That way everybody will be evaluating them in the same way. You do need to be certified for this. For nurses in most hospitals in Indianapolis, that's going to be at least yearly. And basically what it does is it determines the stroke severity and where their deficits are. And so it's a very important tool to standardize the assessment of those patients. Modified Rankin Scale measures the degree of disability in a patient who's had a stroke. This is an important one so that we know as nurse case managers what they're going to need after they are done with the acute phase of their hospitalization. The Barnes Dysphagia Scale, this is kind of a bedside swallow study for nurses to do on patients who have had strokes. Our speech therapists are not available 24 hours a day, and we need to know if they're safely able to swallow. This will also determine if they need help protecting their airway, so it's a very important test. You also have to be certified in this. And so this is an important for dysphagia, okay? So this is just a review from MedSurg 2. Right-sided brain damage. If your stroke is on the right side, you're going to have left-sided effects. So if you might be paralyzed on the left side, which is our hemiplegia, or you might have hemiparesis, which is decreased sensation. Left-sided neglect is where you are unable to perceive the left side of the room or your vision field. They often have spatial or perceptual deficits. They may tend to deny or minimize problems. So that one thing that comes in mind is they're bed hoppers. They forget they've had a stroke, or they don't think it's important that they're immobile anymore, and they still try to get out of bed. They have very short attention spans. They move very fast. They're impulsive. They have safety issues, impaired judgment, and impaired time concept. They also, for left brain damage, they're going to have the effects on the right side. That will be your hemiplegia, impaired speech or language, so they're going to have aphasias. The left side, again, is paralyzed on the right side. They're going to have impaired speech or language, aphasias, so that's where the words just aren't coming out. So it might be receptive, they can't understand what you're saying, or it might be expressive, something they're trying to say. They're going to have impaired right and left discrimination, so having issues with understanding what's on the right and what's on the left. they're going to have slow performance. They're going to be very cautious. Unfortunately, they're very aware of their deficits, and they have high incidence of depression and anxiety. They may have impaired comprehension related to language, math, and reading. So CT scans are our gold standard. MRI can also help analyze, but it's not as fast, and it's not available as readily as a CT scan is. But they can use it for later on to compare and identify edema or necrosis. So the very first test they have done is that CAT scan to analyze whether it's hemorrhagic or ischemic. The D-dimer blood test screens for fibrinolysis. Normal is less than 1.37. A high D-dimer can be a sign of a CVA because it's detecting clots. Echocardiogram can identify a clot. It can identify AFib. It can identify a ventricular septal defect. A venous Doppler will also identify a clot, and it can identify the VSD or a DVT. So this slide just shows you the timeline of stroke care. Within 10 minutes, they need to be taken from their home to a stroke certified hospital. Immediate general assessment will be done by a stroke team or emergency physician or other expert within 10 minutes of arrival, including getting the order for an urgent CT scan. We also, as nurses, and you'll be receiving orders to make sure we're maintaining their ABCs, their airway, and their breathing and their circulation. But we'll also do tests to make sure it's a stroke. So those two tests that differentiate it are a blood glucose and alcohol level, because hypoglycemia and drunkenness can also emulate symptoms of a stroke. The neurological assessment by the stroke team will be done within 25 minutes of arrival, and so CT scan should be interpreted within 45 minutes. And then the initiation of fibrinolytic therapy, if appropriate, will be within 1 hour of hospital arrival and 3 hours from onset of symptoms. It can be administered in well-screened patients who are at low risk for bleeding for up to 4.5 hours. So door-to admission time should be 3 hours for all patients. This is just a flow chart of the same thing. So we have an absolute exclusion. So this is who cannot get TPA. And then we have all the way to inclusion therapy. So people who can get it, I'm going to read that part. They have symptom onset within the last 3 hours. They're 18 years or older. And they have had an ischemic stroke with neurological defect. They can't have a hemorrhagic. It has to be ischemic. And their blood pressure is less than 185 systolic and less than 110 diastolic. They have to have controlled blood pressure because out of control blood pressure and really high can increase the risk of intracranial hemorrhage. And then the absolute and relative exclusions, those are just, they've had surgery, they've had trauma, they've had something that might cause bleeding. So those are basically what those amount to. So fibrolytic or thrombolytic agents would include tissue plasminogen activator or TPA. The dose is always 0.9 milligrams per kilogram, and the max dose is 90. 10% of that dose is given over 1 minute, and the remaining is given over an hour. There is, again, we're going to say this again, there's a 3-hour window after onset of symptoms to start this treatment. After After this treatment, we will not start anticoagulants for at least 24 hours after TPA because of the risk of bleeding. But they probably will be started on something because their mobility is decreased. Antiplatelets will also be started to help prevent further strokes, but it will be started 24 hours after TPA. So blood pressure management, we need to keep it below 185 and systolic and below 110 diastolic to avoid intracranial hemorrhage. You may use nitroglycerin paste, labetalol, nicardipine, that's a drip, or a nitroprusside, and that is also a drip. So management of hemorrhagic stroke includes care on the ICU or stroke unit. The goals of treatment for hemorrhagic stroke are to allow the brain to recover from the initial insult or bleeding, and to prevent or minimize risk of rebleeding, and to prevent or treat complications. Management can include bed rest with sedation to prevent agitation and stress, management of vasospasms, and surgical or medical treatment to prevent rebleeding. So to prevent strokes with aneurysms, we do have a procedure called a cerebral aneurysm clip, and that is they actually clip the aneurysm at its neck, or the part that starts to pouch out, to prevent a large hemorrhage. So basically they're going to put a clip there so it cannot continue to expand and then rupture. Embolization is usually a really good solution for inaccessible aneurysms and also AVM. So basically they're going to take a catheter and it's going to go in your cerebral artery, and they're going to inject a glue, and they're going to basically glue it shut. A carotid endarterectomy, so this would be for our CAD people, not CRD, but our cerebral artery disease, right? And it removes plaque from the carotid artery, because that's where most of those plaque thrombuses come off, is in our carotid artery. It's a very common place to collect it. So when you've had this procedure, you need to watch your patient's blood pressure closely. And if the blood pressure becomes too low, they can start to have ischemia in the brain. And if it's too high, they may have a hemorrhage. So it's kind of basically you need to have very tight blood pressure control post intervention. This slide just shows you that there is so much that happens to patients with strokes. They have the hospital and acute care stage, then they might have skilled rehab, then they might go to the home health, and then they might have lots of outpatient care. But it's a very lifelong and a big source of America's disability. There's a lot of people who have had strokes that require lifelong care. So after a stroke, our goals of care should include decreasing the intracranial pressure. Okay, how do we do that? Some simple ways would be to have the head of the bed up, because the lower our head, the more increased cranial pressure we have. Head in neutral position, so that's our neck and our head facing forward and not bending too far. So if you see your patient's chin and it's on their shoulder or on their chest, that is not neutral position. Avoid hip and flexion, so that would be bending at the hip or hips that are 90 degrees or more. Avoid clustering activities, so it's extremely stressful on them to have a lot of activities at once, so we're going to spread those out. When our patient becomes stressed and overstimulated, they have an increase in intracranial pressure. So they're going to have impaired physical mobility, So we're going to be doing range of motion for them, or we're going to get them to do active range of motion. We want to prevent contractures. It's very common after stroke because of the lack of mobility and decreased sensation. So they will probably have splints to put their body in proper alignment. We are going to want to prevent DVTs. So they'll be on heparin or Lovenox. This is the unilateral neglect. So we were talking about that neglect. So they aren't able to see the affected side. Okay, so when they look at their dinner tray, for example, they only see half of it. So the only way to overcome this visual deficit is if they turn their head to the affected side. So they have to actually turn their head to see even more of the picture. And so it's really important to teach them to turn their head when they need to wash or dress the affected side. Impaired verbal communication. So aphasia happens often with cerebral hemisphere damage. They're going to have slurred speech. Loss of motor function to the tongue can happen. Speech could be weak, where they almost whisper, because not only does speech have a thinking component, it has a motor component. And we will use alternative forms of communication like pictures or gestures. Impaired swallowing. So what do we do for that? We're going to have the chair up in a chair for meals. They may need to flex their head slightly forward during swallowing. It helps make sure the epiglottis closes to the trachea. They might be on a mechanical soft diet or a puree diet, so they don't have to chew large chunks. Remember, they're having impaired motor function. Okay, so they might use thicket or thickening products to make it a manageable consistency. So the thicker the food or the fluid, the less likely it has the chance to slip into their trachea and then into their airway. So we may use that. So there's nectar thick, there's pudding thick, there's honey thickness. So there's different thicknesses that we can use to help reduce the chance of aspiration. And when we're feeding them, we're going to put the food on the back of the tongue. A lot of times they have trouble with moving their tongue, and it's called tongue lateralization. So they'll have trouble moving the food around to the back of their tongue. So this just kind of helps get them a step forward. Incontinence. This is the #1 reason why people are put into nursing home care. And so to help maintain continence or to improve skin and continence care, we're going to toilet every 2 hours. We're going to make sure we give free fluids up to 2,000 mL a day if they're allowed. We're going to do post-void residuals with our bladder scanner to assess the effectiveness of training. They're going to have decreased mobility, so that fluid plus fiber is going to help them to have a good bowel program. They may be on docusate sodium or suppository, or even may require digital stimulation to establish a bowel program. So when you have paralysis or hemiparesis and you don't have sensation or movement well in your bowel, you're going to have constipation. So we almost have to treat them like a spinal cord injury. So we're going to monitor for neuro changes. So we need to recognize, especially in our acute care situation, deterioration, because they can deteriorate or their symptoms may become worse after they're admitted. And we're also going to watch for seizures. Anytime anything goes wrong in the brain, our body may have extra electrical activity, which is the seizures. So that is something to watch for. We're going to monitor for complications. Do they have new bleeding? Do they have vasospasms? Do they have increased intracranial pressure? Are they aspirating? Do they have a DVT? Do they have a decubitus ulcer? Do they have pneumonia? Have they developed a contracture? So these are some things that we're going to be monitoring. So when we're educating the family, we're going to give them general definitions of stroke, why maybe they had it, and interventions. And we're going to give specific interventions for patients with disabilities. And most of them will go on to some sort of rehab, whether it's in the home or in a skilled nursing facility. I have some videos to watch.